Hello students. So let us talk about some important guest questions which I think could be asked in anesthesia. So my first question, which I think is a very probable question, is from oxygen therapy. And similar kind of question was asked in INICET, it was asked in NEET also, and it's very frequently from this topic questions are asked in your FMG exam. So let us talk about the first question. A post-operative patient requiring oxygen supplementation. So a patient requires oxygen therapy. The nasal cannula was attached, and FiO2 of 0.45 was required. So we need an FiO2 of 0.45. What is the flow rate of oxygen which is required to be kept to achieve FiO2 of 0.45? So the simple question is that in nasal cannula, right, what flow rate would achieve FiO2 of 0.45? So this is the question. Okay. So nasal cannula, what is the flow rate which we keep? So let us talk about nasal cannula. So nasal cannula, it's a low flow variable FiO2 delivering device. The first point of nasal cannula is, it is low flow variable FiO2 delivering device. FiO2 delivering device. Okay. So what is the flow which we keep? So it's a low flow. What is the flow actually we keep? We keep 1 to 6 liters per minute. We can start with 1 liter and at most 6 liters per minute. If you keep more than 6 liters per minute, it will not give much benefit. Rather, it will cause problem to the patient like dryness of nasal mucosa, etc. So, what is the FiO2 which it achieves? It achieves FiO2 between 0.22 to 0.45. So, this is the kind of FiO2 which is achieved by nasal cannula. So, how this FiO2 is achieved? What is predicted when we are giving oxygen through nasal cannula? Per 1 liter per minute of the flow, approximately 4% of oxygen is increased over the room air. 4% of oxygen is increased above room air. Okay. So, if I am giving 1 liter per minute, okay, by nasal cannula. So 1 into 4. So 4% over room air, that is 4% plus 21 or 20, whatever you consider the room air oxygen concentration. So we will achieve 25% of oxygen concentration. So we'll achieve 0.25 of FiO2 at 1 liter per minute at most, maximum. We can achieve less than this but not more than this. So 0.25. Okay. If I am giving 6 liters per minute, okay, I'm straight away coming on 6 liters. Similarly, you calculate for 2 liter, 3 liter, 4 liter, etc. So if I am giving 6 liter per minute, so 6 into 4, that is 24% above the room air. So 24 plus 21, that is 45%, right? So we will achieve 45% oxygen concentration. So maximum it can achieve 0.45%, right? And in best way, in minimum, it can achieve 25% or even less than. It is not necessarily that you always achieve what is the predicted. This is the maximum we will achieve, 0.45. But depending upon the breathing pattern of the patient, we can achieve even less. Okay. So it can be less than the predicted, but it cannot be more than the predicted. Remember that. Okay. So maximum FiO2 which nasal cannula can deliver is 0.45. Okay. And so what is the question? That we need FiO2 of 0.45. What should be the flow rate which we need to keep in this patient? So definitely the answer is 6 liters per minute. If I keep the flow 4 liters per minute, 4 into 4%, that is 16%. This is above the room air concentration. So I add 16 plus 21. This comes out to be 37%. So approximately 37% FiO2, that is 0.37. 37% oxygen concentration we will achieve. 6 liter I told you, 6 into 4%, that is 24% above the room air oxygen concentration. So 24 plus 21, this comes out to be 45%. 2 into 4%, that is 8%. So 8 plus 21, that is 29% oxygen concentration it will achieve. 3 into 4%, that is 12%. So 12 plus 21, this is 33% oxygen concentration. Okay, so this is how 4% for every 1 liter. So for 0.45, maximum 6 liter per minute. And definitely, we keep the flow between 1 to 6 liter per minute. So this is for nasal cannula. How do we calculate the FiO2 which it will achieve? Plus, one very important thing we need to know. It's a low flow device because we are keeping a very low flow, 1 to 6 liter per minute, and variable FiO2. What do I mean by variable FiO2? The FiO2 is not independent of the patient. It is dependent on patient's breathing pattern. If the patient's breathing pattern is stable, then only we can achieve the FiO2 which is predicted. Otherwise, the lesser FiO2 will be achieved. So we need a patient with stable breathing pattern. So variable FiO2. So FiO2 depends on patient's breathing pattern. Patient's breathing pattern. It is not independent of the patient's breathing pattern. Okay, so remember this. For all the variable FiO2 devices, oxygen therapy devices, the FiO2 which we predict, which can be achieved by that device, depends upon the patient's breathing pattern. It is not independent of the patient's breathing pattern. High flow fixed FiO2 delivering device achieves a fixed FiO2 independent of the patient's breathing pattern. Okay, so let's just see this chart. Okay, for oxygen therapy, let us first talk about low flow oxygen delivering device. Low flow oxygen delivering device deliver variable FiO2. Okay, so first we talked about nasal cannula. Nasal cannula, 1 to 6 liter per minute is the flow we keep, what we have already discussed, and for every 1 liter increase, we add 4% FiO2 above the room air. So 24 to 44%, or even less than 24% will be achieved, but not more than, let's say, 44 to 45% will be achieved by nasal cannula. Okay, then simple face mask. This is again a low flow variable FiO2 delivering device. The flow rate which we keep 6 to 10 liter per minute. Minimum 6 liter per minute we have to keep in face mask. You see 6 liter. In nasal cannula minimum flow 1 liter, but in face mask the minimum flow 6 liter because it's an enclosure and patient breathe out in that enclosure. So expiratory gas is also in that enclosure. We need a certain flow to wash out that expiratory gases. Okay, so we have to keep a minimum of 6 liter per minute and we go maximum to 10 liter per minute. And what is the FiO2 achieved? 35 to 60%, right? 35, round about 35 to 60% by the face mask. Okay, now these both devices, the nasal cannula and the face mask, these are used for mild to moderate hypoxemia. Right? So it is used for treatment of mild to moderate hypoxemia. Now we have low flow variable FiO2 device which can be used for treatment of severe hypoxemia, and that is NRM or non-rebreathing mask. NRM or NRBM. And what is the flow rate we keep in NRM or NRBM? We keep 15 liter per minute. We can start with 10. And we maximum keep 15 liter per minute. And what is the FiO2 which it achieves? It achieves from 65 to 95%. Roundabout we say 0.7 to 0.9 approximately, that is 70 to 90% or 65 to 95%, whatever. So it is achieving a very high FiO2. So this is used in severe hypoxemia. But one very important thing about these old devices which we have discussed till now, that is nasal cannula, simple face mask or NRM, they all are variable FiO2 delivering device. What do I mean by variable FiO2? The FiO2 which I think the device can achieve, it will only be achieved depending upon the stable breathing pattern of the patient. If the patient's breathing pattern is stable, then only this FiO2 will be achieved. Otherwise, we will not achieve this FiO2, right? So it is variable FiO2. Now let us talk about fixed FiO2 delivering device. Okay, high flow, let's forget this. High flow fixed FiO2 delivering device. Fixed FiO2 delivering device. Okay, fixed FiO2 delivering device in which we need to know about two devices. One is Venturi mask, right? It's a mask, but it's a high flow oxygen delivering device with fixed FiO2. And other is HFNC, that is high flow nasal cannula. Now first talk about Venturi mask. Now how is Venturi mask different from the simple face mask. Now, Venturi mask is attached with a Venturi barrel. I'll show you the image of Venturi barrel. This is a Venturi barrel. Now, in simple face mask, the oxygen tubing opens in the mask itself. It opens in the enclosure. But in a Venturi mask, we attach the oxygen tubing to this barrel. This is Venturi barrel. Okay, Venturi barrel. And as you can see in the image, it is color coded, right? And on every barrel, it is written what FiO2 it will achieve and what is the flow rate we have to keep, the oxygen flow rate. If I keep in the blue Venturi barrel 2 liter per minute of the oxygen flow, I will achieve 24% of oxygen. If in the white one, I keep 4 liter per minute, I will achieve 28% of oxygen concentration. In yellow, 8 liters, 35%. In red, again 8 liters, 40 to 45%. Okay. And in green, 15 liters is maximum and 60% FiO2 will be achieved, right? So, it is color coded and depending upon the Venturi barrel, which is the flow rate we have to keep and desired FiO2 we will achieve. And these FiO2 which is mentioned, that is 60%, 40% is fixed. It is not dependent on patient's breathing pattern. So, what did I say? Venturi mask, it's a fixed FiO2 delivering device. Okay. Now, this is based on Venturi principle in which is again a modification of Bernoulli's principle, in which when we give, see, if you just see that, let's say this is a Venturi barrel. Okay. This is a Venturi barrel. Okay. Now, this is the point, this narrow tube in which we attach the oxygen tubing. So, oxygen is passed through the narrow tubing and then it goes into the barrel, Venturi barrel, which has a diameter more than this narrow tubing. And there are some gap, the holes created in the Venturi barrel. So, what happens? When the gas, high flow gas, passes from a low volume to high volume, the volume has increased. What happens? The pressure reduces. So, when there is a less pressure in this barrel, air is sucked in from the atmosphere. So, if I am giving, let's say, in green, through green Venturi barrel, 15 liter per minute of oxygen flow, right, through this tubing. It sucks 45 liter of room air. So, total flow going to the patient is 60 liter per minute. So, it is high flow. It is giving 60 liter per minute, right? And the FiO2 achieved is also fixed. So, high flow oxygen delivering device, they achieve fixed FiO2, Venturi mask, and it has color coding blue, white, orange, yellow and red and the green adapter. Now, try to remember the image of the Venturi barrel and try to remember the flow rate of green adapter and the FiO2 it will achieve. The green adapter 15 liter per minute is the flow rate we have to keep and it achieves a FiO2 of 60%. So, this is what is so commonly asked in exam, the Venturi mask, a high flow fixed FiO2 delivering device. Then we have HFNC, high flow nasal cannula. Now, it is different from conventional nasal cannula. HFNC. In HFNC, there is a blender in which oxygen and air mix in a fixed concentration, which is let's say fixed by us, and then it is heated and humidified, and with a high flow it goes to the patient. Okay, so it's a high flow nasal cannula, HFNC. Okay, the flow which we keep is 30 to 60 liter per minute and it can achieve FiO2 of 21 to 100%. So, I am talking about HFNC, that is high flow nasal cannula, right? So, what did I tell you about this? I told you HFNC is a high flow device. So, what is the flow in it? 30 to maximum 60 liter per minute and it is fixed FiO2. So, it's a high flow device and it has fixed FiO2. Fixed FiO2, that is FiO2 between 0.21 to 1, right? It can achieve 21 to 1%. It has a blender which mix oxygen and air. It has a humidifier which humidifies the oxygen and air and it goes to the patient with a high flow. So, it produces a positive airway pressure, it produces a positive airway pressure and very important, it produces positive airway pressure and apart from this, it decreases dead space, space. So this is HFNC. Okay. So this is again a high flow device. So these are the important point about the first question which I wanted to discuss, which was the question on oxygen therapy. So oxygen therapy is an important topic for you. Oxygen therapy. Okay. So we have talked about oxygen therapy. Now let us talk about next question. A 2-year-old child was playing with marbles, suddenly went limp and became unresponsive. Mother of the child was beside him and saw him collapse. So mother saw him, witnessed, it was a witnessed collapse. Okay. What is the first step to be done by mother in the situation? Okay. So it's a witnessed collapse. It's a witnessed collapse. Okay. And child is unresponsive. Unresponsive. So what did I tell you? In unresponsive, we have to go for BLS approach, basic life support approach. So what flow chart of BLS we will follow in this? So we have to follow the BLS. It's a child and we have one single person accompanying the child, that is the mother. So we will go for the basic life support chart for a single, let's say, rescuer in a child. Okay. So this is the pediatric cardiac arrest algorithm for a single rescuer. So let us put this question in this flow chart. Okay. So first is whenever we have unresponsive person, let's say unresponsive person. So what is the first thing we do? We verify the scene safety. So it was a house, scene was safe. Okay. Victim is unresponsive. Yes, victim is unresponsive. We shout for help. We activate the emergency system. Okay. So first step is activation of emergency medical system. We'll call for help. We'll call the hospital to come to help us. After that, we will look for breathing or whatever, movement of the chest, and we'll feel for the pulse. This is a 2-year-old child. So we can either feel femoral or the carotid. So femoral or carotid for the pulse. Okay. For in less than 10 seconds, like within 10 seconds, we have to feel it. Now, 3 situation, normal breathing and normal pulse. Both pulse and breathing is normal. Then we just we wait for the emergency medical system because child is unresponsive and we put the child in recovery position. Recovery position. This position is preferred in unresponsive person with pulse and breathing present. This position prevent aspiration. Okay. Now, there is no normal breathing. I could not see the chest movement, but there is a pulse. So this is a respiratory arrest. Respiratory arrest. Okay. So what do? I provide the rescue breath. One breath every 3 to 5 seconds. That is 12 to 20 breath in a minute for adult. And let's say in smaller children, we can go for 20 to 30 breath per minute. So 12 to 20 breath per minute, and for smaller children, we can even increase it to 20 to 30 breath per minute. In child, we feel for the pulse and we also count the pulse. If the pulse is less than 60, this is different from adult. In adult, if there is a pulse, there is a pulse. We don't count it. Here we have to count the pulse. If it is less than 60 and it is not improving with rescue breath, then we have to add the chest compression as well. So less than 60 and signs of poor perfusion. Well, we have to activate the emergency medical system if already has not been activated, and we have to continue the rescue breath, and still there is no improvement in the, let's say, pulse rate. We add CPR, that is chest compression. We add the chest compression. Okay. Okay. If there is no breathing, only gasping and no pulse. So no breathing, no pulse. So this is cardiac arrest. Cardiac arrest. And this was a witnessed cardiac arrest, witnessed sudden collapse. Yes, it was the witnessed collapse. So we will activate the emergency medical system. So I will just put the chart on hold at this point and come back on the question. So 2-year-old child, the playing with marbles, suddenly went limp and became unresponsive. Mother of the child was beside him. So it was a witnessed arrest and saw him collapse. What is the first step to be done by mother in the situation? Okay. Immediately she will call for emergency medical system, right? In a witnessed arrest, it is also suggested call for emergency medical system. in unresponsive, as soon as possible, try to call for emergency medical system. Okay. Okay. So mother will call for help. This should be the answer. Okay. First she will call for help. Once she has called for help, then she will feel for pulse and assess the breathing. So this should be the first step. This should be the second step, right? And in case there is no pulse, no breathing, then this should be the third step. And open the oral cavity and look for the marble. This is no step. We never do it. Now, when we can see the oral cavity and look for the marble? If the child is responsive. So, the child was unresponsive. We go for BLS. If the child is responsive and we think the child has choked on something, responsive after choking, right? Same case, but child is responsive. Then we go for Heimlich's maneuver. Heimlich's maneuver, right? We give abdominal thrust and try to increase the intra-abdominal pressure, which will increase the intrathoracic pressure, and try to remove anything the child has choked on. So we go for Heimlich's maneuver. 2 years old child, any person above 1 year of age, we go for Heimlich's maneuver in case of choking and the person is responsive, right? If the person becomes unresponsive, we go for the basic life support approach. Okay, so what did I tell you? I told you that if someone has choked, right, two things can happen. The person can initially remain responsive. If the person is responsive and more than 1 year of the age, we go for Heimlich's maneuver, right, which is abdominal thrust, okay? And if the person is unresponsive, okay? If the person is unresponsive, then we go for basic life support. We go for basic life support, right? And in case of choked victim who is unresponsive, we immediately go for basic life support. We don't even check for the pulse and breathing. We start with chest compression. Okay? So when someone is alone and if it is a witnessed arrest, in case of children, you always call for help and then come for resuscitation. If it is unwitnessed arrest, if it is not a witnessed arrest, if it is unwitnessed arrest, then in case of that, we go for once, let's say 5 cycle of 30 compression and 2 ventilation, right? We begin the cycle of 30 compression, 2 ventilation. We give it for 5 minutes, that is 5 cycles. And if still we are alone, some help has not come, then we go and try to activate the emergency response system, right? Once the emergency response system comes with AED, automated external defibrillator, immediately we attach it. We have to attach it immediately. So AED is when it comes, it is attached immediately. And AED analyzes the rhythm. If it is shockable rhythm, AED, we give a shock and resume compression ventilation. If it is non-shockable rhythm, we resume compression ventilation. We don't give a shock. Okay. So this is how we practice in case of a child with a single rescuer. So again, I will just revise it, right, for you. But let us, before revision of this flowchart, go for a pediatric BLS with more than one rescuer. So this is pediatric BLS with more than one rescuer. Matlab, we have one rescuer plus one more or more than one. Okay, simply 2 or more. Okay, so we do the same thing. We verify the scene safety, check for the responsiveness. No response, one rescuer will start the resuscitation and other will activate the emergency system. So immediately the resuscitation is started. We look for the pulse and breathing. So pulse and breathing, we look for the pulse and breathing. And similarly, like earlier flowchart, if both are present, recovery position. If breathing is absent, we go for rescue breath. And if both are absent, no breathing, no pulse, then it's a cardiac arrest. We start with CPR. And when we are single rescuer, the compression ventilation ratio is 30:2. And when the other rescuer comes back, it becomes 15:2. 15 compression, 2 ventilation. Now we go on doing this till the emergency medical system comes with the AED. As soon as AED comes, we attach the AED, and according to the rhythm, we continue. If it's a shockable, we give shock and then do CPR. If it is non-shockable, we don't give shock. We continue with CPR. Got it? So this is the flow chart for more than one rescuer. So very quickly I will revise. In pediatric BLS, what are the important points that we have to remember? Pediatric basic life support. Okay. In pediatric BLS, first thing, when we are looking for we are feeling for the pulse. Which pulse we feel? We feel either femoral or carotid. Okay. Femoral or carotid. Okay. If it is infant also I'll discuss together. Infant, which pulse we feel? We feel only brachial. We have to feel for the brachial pulse. So in pediatric, it is femoral, carotid, infant, brachial. In adult, only carotid. Okay. Then, next important thing, if it is witnessed arrest. If we have seen the arrest to happen, then we activate emergency medical system first. We activate emergency medical system first. Okay. If it is unwitnessed arrest, if it is unwitnessed arrest, then we give 2-minute BLS. Give 2 minutes basic life support, the compression and ventilation, right? Both in infant and child. Give 2 minutes basic life support, and then you call for activate EMS, then activate EMS, okay, in case of unwitnessed arrest. This is different from adult. In adult, witnessed or unwitnessed, always EMS has to be activated first. In child, if it is witnessed, then we activate EMS and then come back for resuscitation. If it is unwitnessed, then we give 2-minute BLS and then activate the EMS, okay. Then if the child is in arrest, cardiac arrest, okay, if it is cardiac arrest, okay, so we are talking about child and infant. So if it is cardiac arrest means no pulse, no breathing, no pulse, no breathing, right? Pulse is also not there, there is no breathing. In case we start with high quality CPR, and in that the rate of chest compression in both child and infant, it is 30:2, if there is a single rescuer, right? 15:2, if we have more than one rescuer, right? If more than one rescuer, the compression ventilation is 15:2. Okay, I mean this is ratio, not rate, ratio. Now rate of chest compression, that is how many compression we should give in 1 minute. For any adult, pediatric or infant, it is always 100 to 120 compression per minute. 100 to 120 compression per minute. So 100 to 120 compression per minute, right? Depth. In case of adult, the depth is at least 5 centimeter. In case of child, it is about 5 centimeter. And in case of infant, it is about 4 centimeter. Okay, so keep this in mind. So these are the important differences which we need to keep in mind. Now, if I am saying, if let's say I have activated the EMS and I have got the AED is available. So we have to immediately attach the AED. In adult, in pediatric, in infant, if AED comes and person is in cardiac arrest, immediate attachment, okay. For children less than 8 years, right, we attach pediatric pad. Less than 8 years, we attach pediatric pads. And if it is more than 8 years, we always attach adult pads. So keep this in mind, okay. Pediatric pad has wire which will decrease the energy of the shock. Adult pad will give the full shock, okay. So in less than 8 years, pediatric pad, okay. Now in pediatric, like in pediatric BLS, how do we do the chest compression? Either single hand or double hand like adult, or 2 hand like adult, depending upon the build of the child. And if it is infant, we go for 2-finger technique or thumb encircling technique. We encircle the chest with our hand and with thumb we do the chest compression. So in children, how do we do the chest compression? How do we do the chest compression. In pediatric, it is single hand or double hand. Single hand or double hand. In infant, it is 2 finger or thumb encircling technique. Thumb encircling technique. Okay? Right? So this is how we manage a pediatric patient gone into cardiac arrest. BLS, we talked about basic life support. Okay? Now let us talk about another question. Similar question. Now this question is on neonatal cardiac arrest. Guys, we talked about pediatric and infant. So what is pediatric and infant age group? Infant less than 1 year, excluding newborn. Excluding newborn. Okay? Pediatric 1 year to puberty. 1 year to puberty. So these two we discussed in the previous question. Adult, anything above puberty. And now I will talk about newborn. Newborn resuscitation. Newborn resuscitation in this question. So infant is excluding newborn. Let us talk about newborn resuscitation. So in this question, in a neonatal resuscitation, positive pressure ventilation is given with FiO2 off, right? So 21%, 30%, 100%, 60%. In any of these, infant, pediatric, adult, if I am doing positive pressure ventilation with bag and mask, we always give 100% FiO2 in cardiac arrest. But in neonate, there is some differences which we need to know about. So let us see this flow chart. Well, if newborn is born, if a child is born and goes into, let's say, is compromised before the, let's say, delivery of the child or before taking out the child by C-section, whatever, we know the child, the probability the child will be a compromised child. So we already keep ourselves ready with everything. We have a neonatal resuscitation team ready, we have equipments ready, we have oxygen supply ready, everything ready. Okay. So antenatal counseling and team debriefing and the equipment check if we are expecting a compromised newborn. Okay. At birth, no child is born. It's a term gestation. Well, yes or no, whatever. Good tone, good muscle tone, not atonic, and breathing or crying, whatever a normal child is born with, breathing and crying. If all these are present, then infant stays with mother and go for whatever normal warmth and moisture through mother skin to skin contact. If this is not there, there is, let's say, hypotonia or no cry or whatever, no, then we just stimulate the child. We warm the child, we clean the child with a soft cloth, we maintain the temperature, position the airway, clear the secretion with just the suction, small, let's say, the balloon suction which we use in neonate, and we slightly just stimulate by a pat or something like on the back of the child. If there is still no breathing, this does not stimulate the breathing, okay, then we go for, let's say, this part of the flowchart, but before, let's say, this stimulates the breathing, okay. So when we give the stimulants, it stimulates the breathing, but the breathing is still the labored breathing and the color has not been attained, the child color has not become pink. Then we give little bit oxygen support. We position the clear the airway and we attach the SpO2 and we supplement the oxygen as required, right? We supplement the oxygen as required and we consider a positive airway pressure to be given, right? But child has his normal breathing. He has his breathing, but breathing is still labored. If there is no breathing, then we go for positive pressure ventilation, right? We give positive pressure ventilation and we put a SpO2 monitor. Because how much oxygen we will give through positive pressure ventilation depends upon the saturation of the child. We have heard about the oxygen-induced injury when children, the newborns are given a high FiO2, right? What happens? The let's say retinal fibrillation and all those complication comes because of the oxygen toxicity. So we have to monitor what is our target saturation by SpO2 monitor. And accordingly, we have to supplement the oxygen concentration. So, at 1 minute of the birth, the preductal SpO2 should be 60 to 65%, and at 10 minutes, it should be 85 to 95%. At 2 minutes, it should be 65 to 70%. At 3 minutes, 70 to 75%. 4 minutes, 75 to 80%. And 5 minutes, 80 to 85%. Okay. If it is not in this normal parameter according to the chart provided, then we add supplemental oxygen, and only that much oxygen which will give this target saturation. Got my point? If 20% is giving, we give, let's say room air is giving this target saturation, we'll do a positive pressure ventilation with room air. If we need a higher FiO2, we give positive pressure ventilation with a higher FiO2. Okay. So accordingly, we target according to SpO2. So when we start the chest positive pressure ventilation, we give it with room air. We attach, we give at 21%. We give just, we ventilate. We don't give a high concentration of oxygen. And we consider, we put ECG electrodes. If heart rate remains below 100, if it is above 100, we go for child has recovered. You know, your heart rate is the best indicator of resuscitation in a newborn. If it is improving, the child is improving. Okay. If it is still below 100, then it is child is not improving. We see the check, let's say chest movement, whether when we are ventilating the air is going in the chest or not. If it is not, we reposition everything. We do ventilation corrective measure and again ventilate. And if required, we can intubate at this point of time. Heart rate still below 100 or below 60, it becomes, we intubate if already we have not intubated, and we consider chest compression. So first we ventilate. If ventilation does not improve the saturation, does not improve the heart rate, then only we add the chest compression. In adult, we always start with chest compression in cardiac arrest. Here we go for ventilation, and if the ventilation does not improve the child, then we go for chest compression. So we go for chest compression. We coordinate the positive pressure ventilation with 100% oxygen. Now we give 100% oxygen if the child has not improved. Okay. And if the heart rate remains below 60, and we have already added the chest compression, then we start giving the emergency drug like epinephrine, and we start giving fluid or blood, whatever we need, right? So what we do in newborn, what are the important points that we have to remember? The first point that we have to remember in newborn resuscitation, the first point, inflation and ventilation of the lungs are priority in newborn who needs support after the birth, right? Compromised newborn, the ventilation is the priority. Okay. A rise in heart rate, I told you a rise in heart rate is the most important indicator of effective ventilation and response to resuscitative intervention. Okay. Pulse oximetry is used to guide oxygen therapy and meet the oxygen saturation goal. So pulse oximeter is used to guide the oxygen therapy, whether I am giving room air or I am adding the supplemental oxygen, depends upon the value of pulse oximeter. And I told you what is the value we need to achieve. This is the value we need to achieve depending upon the minutes after the birth. After 10 minutes, definitely 85 to 95%. If it is less than that, we add the oxygen. Before that, we give just room air. Okay. Chest compression is provided if there is a poor heart response to ventilation and right? And even after appropriate ventilation corrective steps, right, still like we are not able to do the ventilation properly, then we normally intubate, right? We do start the chest compression and we normally intubate. Okay. The heart rate response of the chest compression and medication should be monitored by ECG. Here, don't try to feel for the pulse as we feel in infant, child and adult. You go for ECG monitoring to monitor the heart rate. Okay. If the response to chest compression is poor, it may be reasonable to provide epinephrine. See, if chest compression is not improving, then we add epinephrine. And if epinephrine is also not doing the job, then we add the, let's say, blood, or we, let's say, add fluid. We go for volume expansion. Okay. If all these are not achieving the heart rate we want, and let's say oxygenation of the child is not improving, right? Then definitely, let's say after 20 minutes, we start counseling the relatives for the poor prognosis of the child. Okay. So in newborn, first thing we do, ventilation, right? If ventilation does not improve, right? By all ways, by ventilation, corrective measure. Ventilation does not improve the child, heart rate does not improve. Then we add chest compression. Now, if chest compression is also not improving, then we add epinephrine. Then we add fluids and blood, right? This should be the sequence. Got my point? In newborn resuscitation. So let us come back on the question. In neonatal resuscitation, positive pressure ventilation is given with FiO2 of, what should be the answer? 21% initially. So always 21% is what we start with. We target according to the saturation. So target according to SpO2, right? So we start with 21% and we target according to SpO2, right? Okay, so we start with 21%. Remember this. So answer is 21%. Okay. Now coming on the next question, fourth question. A 59 years old male patient with probable stroke was brought to emergency. On examination, his airway seemed obstructed. So the noisy breathing, airway is obstructed and saturation is dipping. This is a sign of obstructed airway. Obstructed airway, if the air passage is not clear, the patient will have noisy breathing and his accessory muscles, etc. will be overused, right? So, and let's say saturation will be also on the lower side. What is the intervention to be done in this patient? So, it's a stroke patient. Stroke patient means non-trauma. So, I just simply divide the patients who come into the ICU in emergency into division: trauma patient and non-trauma patient when we plan for the opening of the obstructed airway. So, divide the patient into trauma and non-trauma. When we plan for opening the airway, we have to do any maneuver to open the airway, opening the airway maneuver, when we have to apply the opening the airway maneuver, right? There are two maneuver which opens the airway, right? One is what? So, what are the options? Let us first see the option. Laryngoscopy and intubation. So, what is the intervention? What is the intervention to be done in this patient? The first immediate intervention. Head tilt, chin lift, second option. Jaw thrust, recovery position to be made. Okay. Now, first, laryngoscopy and intubation. Well, we may require in this patient, but that is not the first thing we do. If the airway is obstructed, it's an emergency, and immediately we have to do some maneuver to make it unobstructed. Second is head tilt, chin lift. If it is non-trauma patient, non-trauma, we always go for head tilt, chin lift. Head tilt, chin lift. So, head tilt, chin lift, with one hand we tilt the head backward and with the other hand we lift the chin forward. This pulls the tongue, which is the main culprit in these patients to cause obstruction. So, the non-trauma patient. And in trauma patient, we go for something called jaw thrust. So, why we go for jaw thrust in trauma patient? I'll just tell in a moment. So, this is a non-trauma patient. It's an emergency obstructed airway. So, what is the immediate maneuver which we'll do? We will immediately do head tilt, chin lift, head tilt, chin lift. So, this should be the answer. Okay. Now, let's talk about head tilt and jaw thrust. Head tilt, chin lift and jaw thrust. These are the two very important maneuvers to open an obstructed airway. So, maneuvers to open an obstructed airway. Head tilt, chin lift and jaw thrust. In head tilt, chin lift, you can see with one hand we are tilting the head backward and with the other hand we are lifting the chin upward, right? In this, there is a movement on the cervical spine. There is a movement on the cervical spine. Okay. So, there is a movement on cervical spine. So, there in this maneuver we have movement of cervical spine. And in jaw thrust, we stabilize the head and neck with both our palm and just protrude the mandible upward or forward. So, there is no movement of cervical spine, right? So, in cervical spine injury, we want if suspected cervical spine injury, we don't want head and neck to move. We want a stable head and neck position, right? And when we want this, we have to go for jaw thrust maneuver. Okay. So, in trauma victim, we always go for jaw thrust. And in non-trauma, we go for head tilt, chin lift. Why? Because this is a better maneuver to open the airway. So, let us talk about head tilt, chin lift. Now this maneuver, the image I have shown you, this is head tilt chin lift. Okay. Now in this maneuver, head tilt chin lift, the tongue is lifted. Tongue is lifted and airway becomes unobstructed. Unobstructed. So this is the purpose of doing this maneuver. This is best maneuver to open airway. Best maneuver to open airway. To open airway. Right? So head tilt chin lift is the best maneuver to open the airway. Okay. Now this, in what is the demerit of this maneuver? Demerit is movement of head and neck joint. Movement of head and neck joint. Head and neck joint. Right? So when there is movement of head and neck joint, right, this should not be done in trauma victim. So not first maneuver, not first maneuver in trauma victim, right? Not first maneuver in trauma victim. Remember this, okay? Jaw thrust. Now jaw thrust, this maneuver also opens the airway by lifting the tongue. So this maneuver also opens the airway by lifting the tongue. So it is also doing the same thing, right? This is inferior to head tilt chin lift. What is the benefit? No movement of head and neck joint. No movement of head and neck joint. So when there is no movement of head and neck joint, this is maneuver of choice for trauma victim. Okay. Remember this. Okay. So this was head tilt and chin lift. Now fourth option was rather recovery position to be made. So what is the recovery position? This is the recovery position. Okay. This is something called recovery position. What is the benefit of recovery position? This position prevents the aspiration to happen. This keeps the food or vomitus, prevents the food and vomitus to go in the respiratory tract. Okay. So this position prevents aspiration. So if it prevents aspiration, what are the patients who are at a high risk of aspiration? Unconscious patient. So unconscious patient. So what did I tell you in the previous question? Unconscious patient, what do? Unconscious patient, we go for BLS approach. Conscious patient, we go for primary ABCDE approach and secondary approach. For unconscious, unresponsive patient, we go for BLS approach. So in BLS approach, we have to see the pulse and breathing. So unconscious patient with pulse and breathing present, both present, are not in respiratory arrest, not in cardiac arrest. So these patients are unconscious with both pulse and breathing. So what do we do in them? We make a recovery position. Okay. So we make a recovery position. So this is a position we have to make in these patients. Okay. Keep it in mind. So this was our fourth option. Okay. Recovery position to be made. This is only done in an unconscious patient with pulse and breathing present. Laryngoscopy and intubation we may need to require in these patients, but it would be after opening the airway when we have oxygenated and now we have time to perform laryngoscopy and intubation, right? So it may or may not be required, okay, in this patient, but it is not the first maneuver. First maneuver is head tilt and chin lift, okay? So this is how you have to approach the question. Okay, next question. Next guess question, right? The next question is from one of my anesthetic drugs, from the drugs I have picked up for you. All of the following anesthetic agents are bronchodilator and can be safely used in bronchial asthma except. So this is a very favorite question. So which anesthetic agent is a bronchodilator? Which anesthetic agent is a bronchoconstrictor? So anesthetic agent or hypnotics. Anesthetic agents or hypnotics, right? They are divided into two: inhalational and intravenous anesthetic. Intravenous anesthetic. Okay. Now, in inhalational, most of the inhalational anesthetic agents are bronchodilator. So, all inhalational anesthetics are bronchodilator. And from best to worst, best is your halothane. This is the best bronchodilator. Then sevoflurane, second best bronchodilator. Then isoflurane and then desflurane. Okay, so this is the sequence of bronchodilation, but all are bronchodilator. So desflurane is bronchodilator, no doubt, but it is a respiratory irritant. So if it is given to a conscious patient, it can cause laryngospasm. So it can cause laryngospasm. So it is not used for induction. Not used for induction. Remember this. If I give it to a conscious patient, right, then only it will cause laryngospasm, because laryngospasm is a reflex closure of larynx. It only happens when the patient is in the lighter plane of anesthesia or unanesthetized. Deeply anesthetized patient will not go in laryngospasm. So this will act as a respiratory irritant only in conscious patient, right? So we don't use it for induction. Otherwise, it's also a bronchodilator. Okay. In IV anesthetic agents, thiopentone. Now, thiopentone is bronchospastic, right? Restall, propofol, your etomidate, your ketamine, right? They all are bronchodilator. They are bronchodilator. So these are bronchodilator. Okay, and if I compare, then ketamine is the best bronchodilator, then propofol, and then etomidate. Okay, so these are bronchodilator. Even benzodiazepine, that is midazolam, benzodiazepine, they are not bronchoconstrictor, not bronchospastic, mild bronchodilation, but these three are good one, with ketamine best bronchodilator. Okay, but thiopentone is bronchospastic. So let us see the options. So all of the following can be used in bronchial asthma because they are bronchodilator, except halothane is a very good bronchodilator, sevoflurane is a wonderful bronchodilator, propofol is a very good bronchodilator, and thiopentone is a bronchospastic. So what is the answer? Answer is thiopentone. Thiopentone has 3 contraindications we need to remember. Thiopentone should not be used in hyperreactive airway, that is in bronchial asthma, we avoid it. So contraindication of thiopentone, contraindication, bronchial asthma, your shock and porphyria. Okay, shock why? Because it's a cardio unstable agent. Porphyria why? Because it's an enzyme inducer. It can precipitate porphyria. So these are 3 contraindications of thiopentone. Just remember it. Okay. Okay. Now in neuromuscular blocker also, since I am talking about bronchoconstriction, bronchodilation, let us talk about other drugs also. So third group of drug which we use during anesthesia is neuromuscular blocker. So neuromuscular blocker, all let's say histamine releasing one can cause bronchospasm. So benzyl isoquinoline group. So benzyl isoquinoline, right? This group, these are histamine releaser. So this group can cause bronchospasm. Right? So what are the drugs belong to this group? Atracurium, cisatracurium, right? Your mivacurium, right? Your D-tubocurare, your doxacurium, the curium ones, right? And aminosteroid, okay? Aminosteroid, no histamine releaser, okay? So it is bronchodilation, no bronchospasm, no bronchospasm. Does not cause bronchodilation, but no bronchospasm. Remember this, okay? So in bronchial asthma, these neuromuscular blockers should be avoided. So what neuromuscular blocker we can use in bronchial asthma? Vecuronium, rocuronium. So vecuronium, rocuronium, these are the good neuromuscular blocker we can use in bronchial asthma. So keep this in mind, okay? Now coming on the next question. The next question which I have picked is from the pre-anesthetic evaluation. A 60 years old patient with a history of severe chronic obstructive pulmonary disease, COPD, presents for an elective hernia repair. The patient has forced expirative volume in 1 second of 60% of the predicted and requires supplemental oxygen on activity. Under what ASA, American Society of Anesthesiologists, physical status classification would you place him? So they have asked question on the ASA physical status, right? ASA physical status. So let us talk about this. What is this? American Society of Anesthesiologists physical status, right? Now this ASA physical status grading system, this give us the grading of this grades the risk associated with surgery. So this assess risk associated with surgery, okay? So this assess the risk associated with surgery. We have ASA grade 1, 2, 3, 4, and I'll talk about 5 and 6 also. So we have total 6 ASA grade, 1, 2, 3, 4, 5 and 6, right? ASA grade 1 means the person who has come for this surgery, the elective hernia repair, has no comorbidity. But in this patient has a chronic obstructive pulmonary disease. So this goes away, okay? So here no comorbidity. Second, ASA grade 2. Patient has a comorbidity, but it is mild to moderate with minimal physical limitation. So here comorbidity which is mild to moderate with minimal physical limitation, okay? So in this question, patient has FEV1 60% of the predicted, which is less than predicted, and requires supplemental oxygen therapy on activity. So on activity, patient requires oxygen. So it is not the minimal limitation or no limitation. There is a limitation on his physical activity. So ASA grade 2 also goes away. Now ASA grade 3, comorbidity with severe limitation, but it is not incapsulating the life. It is not threatening the life, but it is with severe limitation. Then it is ASA grade 3. So there is a limitation. He requires oxygen on activity, supplementary oxygen on activity, right? He is ASA grade 3. ASA grade 4, incapsulating, or we call it life-threatening comorbidity. So it's a constant threat on his life, life-threatening comorbidity, constant threat on his life. This is ASA grade 4. So it is not a constant threat on his life. He requires supplementary oxygen during activity. So ASA grade 4 also goes away. So it is ASA grade 3. Okay. So mild to moderate disease with minimal limitation 2, right? Severe disease with severe limitation is 3, and incapsulating or life-threatening comorbidity is 4. Okay, I hope you got it. 1 to 4 is different, 5 is different. 5 is your surgery is the only option for survival. Patient will die if not operated. Risk of death is there with surgery also, a high risk of death, but whatever chance he has, if the surgery is done. So that's ASA grade 5. Surgery is the only option for survival, is the only option for survival. This is ASA grade 5, okay? And ASA grade 6 is brain dead patient, brain dead patient, brain dead patient for organ transplantation. They are for organ transplantation. So this is ASA grade 1 to 6. Now this ASA grade 1 to 6, this ASA grade 1 to 6, this is for your let's say elective surgery, right? Elective surgery. If we want to use the same grading for emergency surgery, we have to write 1E to 6E. Okay, so E is for emergency. E is for emergency. Okay, so keep this in mind, right? So ASA physical status is telling us the risk associated with surgery from 1 to 2 to 2 to 3, 3 to 4, 4 to 5 and 5 to 6. The risk is increasing. Like in 1, the risk associated with surgery is 0.1% or 0.2%, and in 5, the risk associated with surgery is 80 to 90%. Got my point? So gradually the risk is increasing. So this is ASA grading, and again it's a very predicted topic, and this can be asked in exam, right? Because recently in few exams I have seen questions being asked from this topic. Okay, ASA grading. So now let us talk about the next question. Again, a very predictable topic, that is intravenous cannula. Question on IV cannula. A patient had an injury leading to massive blood loss resulting in hypotension. So patient is in hypotensive shock, right? Patient requires rapid fluid infusion. Which of the following is most preferred IV cannula? Which is the best IV cannula I should use? So pink, orange, gray, green. Okay, so I'll come back on this question. Let us discuss about these IV cannula. So it is pink, right? Then pink, your green, gray and orange. These are the 4 given in the option. Mostly these are used in adult patients. Pink, what is the size? Size is 20 gauge. Green cannula, the size is 18 gauge. Gray, it is 16 gauge, and the orange, it is 14 gauge, right? So the size is gradually increasing. Pink cannula, the flow rate. What is the rate of the fluid which we can give with pink cannula? It is 55 to 60 milliliter per minute, right? In green, it is 90 to 100 milliliter per minute. In gray, it is 220 to 250 milliliter per minute. And in orange, it is 270 to 320 ml per minute, right? So if I have to give a normal saline and it is a 500 ml bottle, with gray I can give in, let's say, 2 minutes, and with orange I can give in 1.5 minutes, right? Okay, then let's say, what is the uses of these cannula? Pink and the green. This is used in wards and in perioperative period. In perioperative period, in wards, right? So these are the regular adult cannula, the pink one and the green one. The gray one, it is only used in cardiac surgery where we need more fluid, faster fluid resuscitation, and in trauma patient, right? When we have to give the fluid fast. Orange, again, mostly in trauma and sometimes required in cardiac surgery as well, where we have to give fast fluid. So in trauma, we'll try to put the cannula which can give the fluid fastest. So which would be the cannula in this case? Definitely the answer has to be orange. This is most commonly used in hypotensive shock to give the fluid as quickly as possible to restore the blood pressure of the patient. So in trauma patient, we go for orange cannula. Thickest cannula given in the option is what we go for. If orange was not there in the option, we would have gone for gray cannula. Got it? So this is how we'll answer the question. Okay. So these are the 4 important adult cannula which I discussed with you. Now next question. Which of the following agent is contraindicated for Intravenous regional anesthesia for IVRA. Again, a very, very popular topic for FMG exams, right? For intravenous regional anesthesia, which is the following agent, which is contraindicated. So many times they have asked which is the agent of choice. Well, which is the agent contraindicated? So many times. So let us talk about IVRA before coming on the question. Intravenous regional anesthesia, IVRA, or we call it Bayer's block, right? In this Bayer's block, I mean, if you see the name, it seems very, very contradictory. We are saying IV and we are saying regional anesthesia. We always give regional anesthesia by locally putting the drug, local anesthetic, near the nerve fiber. But what is this IVRA and why are we saying regional anesthesia? Well, in IVRA, we produce anesthesia of one region only, but through IV route, by giving local anesthetic through IV route. Well, it is given in extremities, either upper or lower. So let's say if I have to give IVRA of my right upper limb, I would tie two tourniquet in this limb and inflate the tourniquet, double the blood pressure of the patient and cut this limb from rest of the circulation. Then I'll put an IV cannula and through that IV cannula will give the the local anesthetic, which will remain in this limb, diffuse out of the blood vessel and block all the nerve fiber of this limb. So one region anesthesia, that's why it's regional anesthesia. Through IV route, that's why it is intravenous, right? Well, if this tourniquet opens, there's a risk the drug can go into systemic circulation. So always there is a risk of systemic toxicity. So we try to use the safest LA, which is lignocaine. And we try to not use unsafe LA, which is bupivacaine. So remember, bupivacaine is most cardiotoxic, and this is contraindicated for IVRA. So answer has to be bupivacaine. Okay, lignocaine is local anesthetic of choice for IVRA. So for IVRA, the local anesthetic of choice is lignocaine. So if they had asked of choice, answer would have been lignocaine, and contraindicated answer is bupivacaine. Okay, remember this IVRA, we have to tie the tourniquet. So there are few conditions in which tourniquet, we cannot tie tourniquet, and in those conditions IVRA is contraindicated. So this is the third question which is asked on IVRA. So what are the conditions which absolute contraindication of IVRA? So there are few absolute contraindication of IVRA. Number one, it is contraindicated in sickle cell anemia because it will precipitate sickling. It is contraindicated in peripheral vascular disease. In this also we cannot tie tourniquet for that long. It is contraindicated in scleroderma. Okay, so these are three contraindications of IVRA, right? Remember that I wrote bupivacaine is most cardiotoxic. Well, local anesthetic is always given locally. We try to avoid it getting absorbed systemically. Systemic toxicity is life-threatening. So let us talk about very important thing related to local anesthetic, that is LAST. What is the full form of LAST? LAST means local anesthetic systemic toxicity. Like local anesthetic systemic toxicity, LAST. Well, LAST, what do I mean by this LAST? In this, local anesthetic which is locally deposited gets systemically absorbed, right? And two important systems can be worst affected by local anesthetic, because local anesthetic, they act on sodium channel, and if they block the sodium channel of heart and brain, it can be deleterious, it can be life-threatening. So systemic toxicity can cause blocking of the sodium channel of brain and heart. So local anesthetic systemic toxicity is life-threatening. So if it goes and attached to the sodium channel of brain, what will it cause? The clinical feature would be apprehension, perioral numbness, right? Tinnitus, seizure, right? And apprehension, perioral numbness, tinnitus, seizure, right? And perioral twitches, So these are the clinical feature of CNS toxicity. CVS toxicity, cardiovascular toxicity. Cardiovascular toxicity, what would be the clinical features of cardiovascular toxicity? In cardiovascular toxicity, hypotension, then arrhythmias, and cardiac arrest. These would be the features of cardiovascular systemic toxicity. Now, these can be life-threatening. This will cause life-threatening. This is life-threatening. So, how to manage the local anesthetic systemic toxicity? First, we practice a lot of precaution and prevent it from getting absorbed systemically. But if it gets absorbed systemically and it is causing systemic toxicity, what is the management? Management is the symptomatic management. Whatever the symptom comes, so symptomatic management. Whatever the symptom comes, we manage the symptom. And first is symptomatic management, and second is your very important 20% intralipid emulsion. 20% intralipid emulsion infusion. Okay. Now 20% intralipid emulsion, when given intravenously, they absorb the local anesthetic, right? The local anesthetic has lipid escape. So this is antidote which we use in last, local anesthetic systemic toxicity. So any question asked on last, you have to answer whatever the symptom is coming, I manage the symptoms. If arrhythmia is coming, I give antiarrhythmic. If cardiac arrest, we do CPR. So what is the symptoms here? Hypotension, I give inotropes. Arrhythmia, I give antiarrhythmics. Cardiac arrest, we do CPR. If it is causing seizure, we give anti-epileptic, right? So we manage the patient symptomatically and we give something called 20% intralipid emulsion infusion. So remember this, okay? Now next question. In a mechanically ventilated patient, tracheostomy was done. Which would be the best tracheostomy tube to be used? So remember, when we have to ventilate the patient, when we have to put the patient on mechanical ventilation, right? There are two type of interface. One is what we call invasive, and other is what we call non-invasive. In invasive we use either endotracheal tube or tracheostomy tube. And in non-invasive we use the mask, the face mask, okay? So non-invasive mechanical ventilation, we use face mask, the interface, patient interface, okay? And in invasive we use endotracheal tube or tracheostomy tube. So if this is the trachea and we are putting the tube, right? Endotracheal tube from oral cavity or nasal cavity, and tracheostomy tube, we make a hole in the trachea, we make the hole in this trachea and we put the tracheostomy tube. So in both the cases, if we do not create a seal in the trachea, right? What will happen? The air which we are giving for ventilation, it will escape from side. So we will not get a proper seal for ventilation. So when a patient is on mechanical ventilation, right? Whenever we do a tracheostomy or we put an endotracheal tube, we always have to put a cuffed endotracheal tube. This cuff creates a seal in trachea, right? This cuff creates a seal in trachea and makes the positive pressure ventilation possible. So we always have to use cuffed tube. So here we have to use cuffed tube, whether endotracheal tube or tracheostomy tube. Got my point? Okay. Now uncuffed tracheostomy tube rarely used in pediatric, right? During surgery and all, right? Normally in pediatric also, during mechanical ventilation we are using cuffed tube. Metallic tracheostomy tube is used when the patient is on long-term tracheostomy just to maintain the patency of the trachea, right? So long-term tracheostomy, right? This metallic tube cannot be used for mechanical ventilation. It does not have the attachment for the mechanical ventilation, the tubing of the mechanical ventilation. So it's only for long-term tracheostomy to maintain the patency, to maintain patency of trachea. So here the patient can breathe, just cannot keep the trachea patent, maybe some obstruction or anything. So we put the metallic tracheostomy tube. It is used for long-term tracheostomy. And fenestrated tracheostomy tube is used for voice, let's say when we, voice or speech, when we are let's say encouraging the tracheostomized patient for producing voice or speech, then only we use this fenestrated tracheostomy tube, which has holes in it for the passage of the air. Okay, so remember this. Okay, now here I just want to tell you the indications of endotracheal intubation, and same are the indications of tracheostomy as well. So indications of endotracheal intubation. First indication, during general anesthesia, right? Second indication, to protect the airway from aspiration, Third indication, for positive pressure ventilation, for long-term positive pressure ventilation, right? And fourth indication is pulmonary toileting, okay? If I see the tracheostomy tube, this was of endotracheal tube. If I talk about tracheostomy tube, okay? Tracheostomy tube, we don't use it for short-term ventilation. So just for giving GA, we will not use the tracheostomy tube. To protect the airway from aspiration, yes, if we need to protect the airway from aspiration for a long time, we use tracheostomy tube. For positive air ventilation, yes, for long-term positive pressure ventilation. And for pulmonary toileting, yes, in number of patients, for long-term pulmonary toileting, we need a tracheostomy to be done. So only for short-term ventilation, GA, that is during anesthesia, we use endotracheal tube. If the patient is in ICU, and for long-term ventilation, we change from endotracheal intubation to tracheostomy tube. Got it? So remember this. Next question. Which of the following agent can be used as a sole agent for induction and intubation? If you see this word induction, right, and inhalational are in the option, you don't have to answer anything else except sevoflurane. Sevoflurane is inhalational induction agent of choice, right? And for number of times, we don't give neuromuscular blocker to the patient. We deepen the patient under sevoflurane anesthesia and we intubate. So when we are, let's say, giving GA, general anesthesia, to pediatric patient, if I'm using inhalational mode, inhalational induction, the best agent is sevoflurane. And under sevoflurane, we can deepen the patient and also intubate. So for inhalational induction and intubation, the agent of choice is sevoflurane. If for the same, I'm using intravenous agent. So what should be the answer? Intravenous. And I don't want to use the neuromuscular blocker here also. So I would go for propofol. Propofol, I can go for induction and intubation. We can give propofol and deepen the patient under propofol, and we can go for induction and intubation. Right? So, understood? So for IV, it is propofol, and for inhalation, it is sevoflurane. But in pediatric, we always prefer the sevoflurane, the inhalational induction mode. Okay, so keep it in mind, right? So for inhalational induction and intubation, answer is sevoflurane. Okay, we don't use. So what are the important questions? This is the respiratory irritant. So not used for induction. right? Halothane, again a good agent for induction after sevoflurane. So can be used for induction. Iso, again irritant, not used for induction. Not used for induction. Okay, so keep this in mind. Okay, there is a case with image given with marked on EtCO2 value 40 mm of Hg. So this is a marking on the EtCO2 value. What is it? What does this value represent? So this is expired oxygen or value of capnography, pressure of gases, pressure of gases while breathing, inspired O2, right? Inspired O2. What exactly is this value? What is this value? This is end tidal CO2. So if we see the capno, like this is a normal capnograph. We see two things. This is CO2 graph against time, and we see two things. We see the shape of the graph, and we see the numerical value which is coming. So here, what was marked? 40. So value was coming 40. What does this represent? This is end tidal carbon dioxide, EtCO2, right? So this is what is the normal value of EtCO2 is between 35 to 45 mm of Hg, right? This is the normal value. So if this is coming 40, this is normal. This is value of capnography. So actually it has gone up and down the options. Expired oxygen, no. Value of capnography, yes, this is value of capnography. Pressures of gases while breathing, no. Inspired oxygen, no. So these are wrong. It is value of capnography. It is value of end tidal CO2. So this is end tidal CO2. Okay. So normal is 35 to 45 mm of Hg. This is a normal shape of the graph. This is normal shape of the graph. Okay, this is normal shape of the graph, right? Now this graph, this CO2 graph against time, this has 4 phases: phase 1, phase 2, phase 3, phase 4. Okay. Now phase 1, what does it represent? Phase 1 represent dead space ventilation. Dead space ventilation. Okay. Phase 2 represent dead space plus alveolar ventilation. Alveolar ventilation. Phase 3, only alveolar ventilation. Alveolar ventilation. And phase 4, inspiration. Inspiration. Okay. Now phase 1 to 3 represents expiration and phase 4 represents inspiration. So this is a normal graph. Okay. Expired. In inspiration, it will touch the baseline, and dead space, the gases are same as your inspiratory gases, so it's a 0, it's a baseline. So phase 1, phase 2, phase 3, phase 4. Okay. Now let us just very quickly discuss some abnormal graphs. So if this is coming 40, 40, 40, let's say, this is normal graph, normal EtCO2 graph against time. Okay. Now, if what happens, if there is a sudden rise in CO2, from 40 it becomes, let's say, 90. So CO2 production in the body has increased. This can be malignant hypothermia. Malignant hyperthermia. So doubling, tripling of CO2, answer is malignant hypothermia. If the value, right, from 40 it becomes 20, then remember, air embolism, right? Sudden drop, sudden fall of CO2. Fall of CO2. Answer is air embolism. Okay. Now, if some, let's say in this graph, let's say the shape changes. This is shark fin pattern, and this is of bronchospasm, right? If in this graph, this is normal, if it baseline gets elevated. This is CO2 rebreathing. CO2 rebreathing. Okay, this is carbon dioxide rebreathing, and this happens when expiratory and inspiratory gas mixes. If in this graph a cleft starts appearing, this is curare cleft. Curare cleft, and this means that patient has started spontaneous breathing during mechanical ventilation. So this indicates spontaneous breathing, okay. So these are the 4-5 different things which we discussed in the graph, okay. Now coming on the next question. Before laparotomy surgery, what advice should be given to an obese patient by the surgeon or anesthesiologist? NPO guideline. NPO 8 hours before OT, NPO 2 hours before OT, NPO 24 hours before OT. No need for NPO in laparotomy surgery, okay. No need for NPO. Now listen, any elective surgery, NPO should be fixed. There is a fixed NPO which we need to follow. So the NPO guideline prior to surgery, NPO guideline prior to surgery. Let's say in adult, we have to remember 2 hours, 4 hours and 6 hours, 8 hours. These are the guidelines we have to remember. In adult, we don't need to remember this 4 hours because 4 hours is for breast milk, which is only required in pediatrics. So we'll talk about 4 hours in pediatric. 2 hours, NPO for clear fluid, like water, coconut water, etc. 6 hours for semi-solid food like dal, khichdi, etc. And 8 hours for full fatty meals. Okay. So what we advise our patient to take a soft meal 6 hours prior to surgery. So in this laparotomy surgery, obese patient who are at a higher risk of aspiration, the guideline is same. There is no change in the guideline. Answer has to be 6 hours, but here 6 hours is not in the option, so we'll go for 8 hours, right? We go for 8 hours as an answer. So answer has to be 8 hours. 8 hours is for full fatty meals, okay? 6 hours for semi-solid fluid, 2 hours NPO for clear fluid. In pediatric, what do? We have 8 hours, 6 hours, 4 hours and 2 hours. Same. 2 hours NPO for clear fluid, 4 hours NPO for breast milk, and 6 hours NPO for infant formula, or cow's milk, anything except breast milk, and 8 hours NPO for full fatty meal, Got my point? So this is what NPO you have to remember in pediatric. So this is a question on NPO guidelines prior to surgery. There is a high risk of aspiration in obese patient, but the NPO guideline for obese, non-obese, for any patient, pregnant ladies, again where the high risk of aspiration is same. So answer has to be same. Remember this, okay? So this is how we have to follow the NPO guideline. And these are my guess probable question which can be asked in exam. So I hope you enjoyed the session. Thank you so much.